My name's Kyle. I'm one of the twos, and my small talk is induced nephropathy with or without. All right, I want to thank especially Dr. Madani for helping me out with this, and the rest of the small talks team, Dr. Crony, Beck Esme, Buckridge. Special shout out to Dr. Sinner and Tang, who I didn't talk to directly about this, but have shared resources and contributed to this topic. I chose this topic because I thought it was interesting and it can help change. It helped change actually how I'm going to practice, and maybe it'll change how you practice. Right. Case one. So we had a patient, hypertension, diabetes, CKD4, presents with GI symptoms, fever, vomiting, diarrhea, is tender, workup is sepsis, and worsening renal function. They're stable, right? So you're going to want to, you're thinking about imaging this person, right? And, do you give contrast, right? Contrast might worsen his kidney function. You're really thinking about this, all right? And the picture I have on my right is a sculpture of the Thinker in front of the Gates of Hell by Rodin, the French sculptor. All right, so you really think about this. You don't want to be the person that gives him the last punch in the kidneys and he's on dialysis forever. All right. Let's see. All right, definitions. AKI, it's an increase in creatinine up from 0.3 or 50% from baseline, or back in the days before they knew what creatinine was, decrease in urine of 0.5 milliliters per kilogram per hour for 6 hours. In a 70-kilogram male like myself, that would be 210 milliliters per hour. And contrast-induced nephropathy is AKI within 48 hours of contrast administration. Kind of related, but not really. This is a purple bag of urine can be seen in urinary tract infections. I saw once as a medical student. Right. Why do we even need imaging for this? One, to aid in diagnosis and treatments of disease, kind of obvious. Our specialists want it. For disability, imagine you're trying to endorse someone to medicine or OB-GYN without getting the imaging that they want. Very difficult. Maybe in the future, when you have better relationships with your colleagues, maybe you can get away with it. But here at King's, I think we definitely need it. It also helps our radiologists, right? You want them to have the best tools for them to make the best diagnoses and the best interpretation of imaging. All right, so why is contrast harmful? So doing the research and the resources I found, a lot of people reference this 1954 study done in Scandinavia. It's kind of more of a case report. This guy with myelomatosis, so the guy had protein in his urine. They did pylography, and the guy stopped making urine for a significant amount of time. They're like, oh, maybe contrast can hurt kidneys. Right. Here's an image I pulled off of Radiopedia, showing just pylography. This is like a normal one. Right, we see the kidneys, right, evaluating the calyces, going on to the ureters and the pelvis. So why is it harmful? Thoughts are the osmolarity of the dye. Back in the day, in the 1954, it was very high osmolality. Nowadays, it can be closer to our own osms, around 300. Iohexol, what we use, is slightly higher than the 320 of ours. And potentially fluid overload, right? We're loading these people with contrast. Quiz. Does anyone know how much milliliters is in an average CT abdomen pelvis of contrast?
I will guess
100 cc. 30 cc. Anybody else? It is about 100 cc's. Correct, Dr. Evans. Yeah. I actually left this up there, and I checked with the radiologist on shift last night, and he was like, yeah, it's like 100. I asked about PE studies and CT abdomen pelvises as well. All right. Moving on. Relationship between contrast and AKI. So there's other studies that show, like when I talked about shedding, not making urine after giving pylography. There's another study in patients that had acute coronary syndrome and cardiogenic shock that went under catheterization, which is with contrast. And people had AKI had a 3 times increase in mortality, and I think it's like a double increase in mortality later on. Another study showed that a CTPE study has higher mortality and renal replacement in patients with contrast-induced nephropathy after they got the CTPE. And that's really what we fear about, right? Outcomes, right? We're going to hurt our patients by giving contrast, right? And we do a lot of things to patients, and we don't want to make things worse. We have a lot of power to do so. Okay, we got to get on dialysis. All right. These studies have a big thing. It's called confounding bias. So a good way to think about this, or else how I think about it, is like ice cream bias, right? So the definition, confounding bias is one variable is linked with a cause when another variable is actually causing it, right? We kind of know this inherently, ice cream sales and penetrating trauma. Ice cream sales don't cause penetrating trauma. It's the fact that it's summertime, right? As we've been in CCT know, there's more people are out interacting with each other, and there's just more incidents of this. Why does this happen? Because there's no controls for the study. What we can't do is give people contrast and give them AKIs until they go on dialysis to know how much contrast to give, right? So it's pretty unethical to do so. And that is why for all these previous studies, there is like a big, there's like lacking true evidence for this, right? Okay. And also another thing is like patients that get this are sick, right? So there's this one study, 32,000 hospitalized patients that just didn't get contrast. 19% of those had a 25% increase in creatinine. So if they would have gotten contrast, technically they would have made the definition of contrast-induced nephropathy. Another study showed, this is more of a recent one, an ED visit. So 17,934 ED visits. The intervention was CT scan with or without, and the rates of AKI were similar in all groups. Contrast is not associated, and then there's a secondary outcome that of like CKD dialysis and transplants, and then none of them had those outcomes in 6 months. This painting is Bacchus by Caravaggio. He was sick in the infirmary. Bacchus is the god of wine, and he's jaundiced. It's one of my favorite paintings. All right. So let's go back to these patients, right? So these patients that we're thinking about getting CT abdomen pelvises or giving contrast to, they're already sick. They already have increased rates of, or higher chance of having AKI, right? They're septic. They might have a PE. They're bleeding out. They're hypovolemic. They might be in shock. We're a big vancomycin shop. How many patients get vancomycin, ceftriaxone, and Bactrim every day? And all these things can cause AKI. How many times do you give Toradol to these patients? NSAIDs also cause AKI. So this is all really, there's a lot of different variables of why these patients can get AKIs, and it's really hard to see like who done it, right? All right, next slide. So what would you do? Okay, so I stole this from MCRIT, who has who's explored this topic probably more in depth than I did today. Algorithm: is it okay to give this patient IV contrast? Is a sick patient needs a CT scan? What is the GFR? It doesn't matter. Could this IV contrast help improve diagnostic imaging and provide barotherapy? No, don't use it. Yes, use the contrast, right? So I think we get a lot really scared with this, right? I think it's not so, we don't worry about it so much in the patient, good, young, they have a slight AKI, and give the contrast anyway. I think we worry about it more in the patient who is on their last legs of kidney disease, right? And you don't want them in dialysis. But if they're already sick enough where you're considering it, right? I would suggest using it, right? And we also have pressure of diagnosis of sick patients, right? They have life-threatening disease, and our decisions of diagnosis and our decisions to use imaging to aid in diagnosis can really help to save them because they're already sick in the first place. All right. If you too long didn't read, hard evidence of contrast-induced nephropathy is lacking due to no control group. There's a lot of confounding variables in these people. They're sick, and we also give them a lot of other medicine that can cause AKI. And if the contrast imaging can help with diagnosis and treatment, I would do it. And this is a kidney punch. Any additions, any questions, anything that I missed, anything that you want to add?